Good evening, friends. Welcome back to Pediatric classes. Today, I'm really happy to discuss an important topic, that is iron deficiency anemia. So, this topic was discussed during the last Kerala Pedicon, which is conducted at Trivandrum. First of all, let me thank the organizers of IAP Kerala and IAP Trivandrum for giving me that opportunity to give this talk during that time. So this was an important discussion which we had during that time. What exactly are the new guidelines or the newer insights into the iron deficiency anemia? Anemia continues to be a global health concern. We have two data, one is from WHO, one is from NFHS 5. The NFHS 6, the survey is done, the results are not yet out. So according to the WHO guideline, WHO data, the children 6 to 59 months, 40% are having anemia, whereas Indian data shows 67.5% children are anemic. About women in the age group of 15 to 49 years, that is women of the reproductive age group, WHO says around 30% are anemic, whereas NFHS India data says it is 57% in India. Globally, about 35% of the pregnant women are anemic, whereas India, we get a prevalence of around 52.2%. Clinical presentation, as you all know, can range from asymptomatic child with mild anemia, or they can have post-scholastic moments, impaired neurocognitive outcomes, decreased immunity, poor exercise capacity, etc. A clinical examination, we will see the conjugal pallor, we can make out the pallor of the arms, and also chylonychia. The anemia is severe, we may even get an ejection systolic hormone. So what are the hemoglobin cutoffs according to the 2024 guidelines to say it is anemia or not? So in the children in the age group of 6 to 5 years, 6 months to 5 years, the cutoff is 11. And 5 to 12 years, the cutoff is 11.5. And 12 to 15, thereafter it is 12. So again, for you to remember, I'll tell you, our doyen of nutrition, mother, Elizabeth Madam, she always used to say, at 12 years, child should have a hemoglobin of 12. So less than that, that is from around 5 years to 12 years, they can have a kind of 11.5, and thereafter it is lesser age, it is 11. So remember this, and also remember non-pregnant women also we expect a cutoff around 12. Whereas pregnant women, the cutoff is 11, and also males, it's 13. What are the causes of microcytic hypochromic anemia? So when I was searching the net, I got this mnemonic in one of the videos. One I saw was, I teach anemic little children becoming scholars. So I for iron deficiency, T for thalassemia, A for anemia of chronic disease, L for lead deficiency, C for lead poisoning, C for copper deficiency, B for B6 deficiency, and S for sideroblastic anemia. This is for PGs and all. If they ask you or study reckoner, you can remember this. And coming to the approach, so when for all the patients we are suspecting anemia, we will do a hemoglobin, right? Yes. Also, always try to do the RBC indices along with, so you get a microcytic, there is a MCV will be less, MCH will be less. So this microcytic hypochromic anemia, you said, also you do the iron studies. Also, you should need to check the RDW, that is red cell distribution width. In a case of iron deficiency anemia, there is anisopocytosis. So you will see different RBCs of different sizes. So RDW will be increased. Whereas in a case of thalassemia, it will be decreased. So RDW, if you get a child with microcytic hypochromic increased RDW, consider iron deficiency anemia. Also do the iron studies. What are the iron studies I will do? We generally do serum iron, serum ferritin, TIBC, serum transferrin, etc. Always you get confused between iron deficiency anemia and anemia of chronic disease. In both these conditions, iron will be less. Okay. But what is the problem there? When you actually see, in a case of iron deficiency anemia, you get a lower serum ferritin. Whereas in a case of anemia of chronic disease, the ferritin, being an inflammatory marker, will be either normal or increased. In a case of iron deficiency, the total iron binding capacity will be more, whereas it will be decrease in anemia of chronic disease. Whereas you get a dimorphic picture in a case of sideroblastic anemia, the major thing is about the ringed sideroblast. So this can be confirmed only by a bone marrow examination. And basophilic stippling, increased serum iron, increased serum ferritin with a decreased TIBC, consider lead deficiency. If you get all the iron profile done and the iron profile is following the normal range, go for the serum electrophoresis, hemoglobin electrophoresis, and if it is abnormal, thalassemia, and it is normal, look for copper deficiency. Now, what are the newer insights into the diagnosis? This we already discussed in their previous years. So, newer insight one is about the use of reticulocyte hemoglobin. It is found that it is a very sensitive marker because the reticulocytes are the first newer cells just produced. So, if you see the hemoglobin of the reticulocytes, if it is decreased less than 27.5 picogram, it is suggesting iron deficiency anemia. And also, you can see for the soluble transferrin receptor levels. So, what happens in iron deficiency? We need to have capture all the iron whatever is available. So the transferrin receptor level will be increased. So normal is 1.5 to 4.5 milligram per deciliter. So when you see, I already told that in a case of an iron deficiency anemia, you can also see for the ferritin level. So what happens is for this ratio of STFR to ferritin in a case of IDA, ferritin is decrease in IDA whereas STFR is increase. So this ratio will be increase in case of iron deficiency anemia. Whereas in the case of anemia of chronic disease, this ferritin level will be very high, no? So the reverse happens. And if you see the level of hepcidin, it will be less than 10 nanogram per ml. About hepcidin, we will discuss in the subsequent slides. So what are the prophylactic treatment to prevent iron deficiency? In a full-term breastfed infants, we can start with at around 4 to 6 months with a 1 mg per kg daily of iron. Or premature infants, we start early by around 2 weeks with 2 mg per kg daily. American Academy recommends to check the CBC around 9 months to 1 year to detect early iron deficiency. See here, there is a very good program which is running in our country, that is the Anemia Book Bharat Strategy, AMP. So this takes care of almost all the age groups. So what are the age group it covers? So first is very small children, 6 to 59 months. What is the iron formulation we are giving there? We are giving iron drops with a dispenser. There is recommended dose is 1 ml. So 1 ml will contain 20 milligram of elemental iron and 100 mics of folic acid. This is given bi-weekly. And whereas children in this age group of 6 to 59 months are given tablets, pink color tablets. So these tablets contain 45 milligram of elemental iron plus 400 mics of folic acid. What happens to adolescent age? Adolescent age and the women of the reproductive age and the pregnant ladies all are having 60 mg of elemental iron plus 500 mics of folic acid. Only difference is the color is different. Adolescents is given blue color, sugar coated, and women of the reproductive age and pregnant ladies, they are given, what is the difference? One is the tablet color is the same, but the frequency of duration in a VRA, that is WRA, that is women of reproductive age, we need to take only weekly. Whereas in a pregnant lady, they have to take it daily for 180 days from the second trimester and continued for 6 months after delivery also. So I hope this is clear. This you try to remember with the pictorial representation. One another thing should remember is about the dosages. Whatever I mentioned, so just glance through it. All you need to know is that from adolescent, WRA and pregnant ladies, the dosage remains the same. Only thing is the how frequent you are giving. In a pregnant lady, you go give it daily, whereas others we give it weekly. And in AMB, they follow 6 interventions. One is about IFA, that is iron and folic acid supplementation. Second is about periodic deworming, intensified ER and behavioral change and communication campaign, testing and treating of anemia using digital methods, mandatory provision of iron and folic acid fortified foods and government-funded health programs, intensifying awareness, screening and treatment of new nutritional cause of anemia. All these are already discussed in a previous video on anemia strategy or anemia. So these are the fortified rice picture I have given. What is one of fortified rice is along the rice kernels in the ratio of 1 fortified rice to 100 real rice kernels, it is mixed and given. So this is will rich in iron and folic acid. But what happens is sometimes people tend to think there is damage or this is not a clean one and they should pick it and throw it up. But it is not that. We have to inform the public well in advance that these are fortified rice that has to be cooked along with the normal rice. So what are the oral formulation available? We have ferrous salts, we have ferric salts, so carbonyl iron, heme iron, polypeptide, etc. The most commonly used ones are ferrous salts, but they have more GI side effects. So all these things are the things right now available. Now, coming to the newer insights into the treatment. The oral iron therapy, the main change which has happened is we are going for again single daily dosing with a lower dose, that is around 2 to 3. 3 is almost 3 mg per kg per day with a tailored duration. So why this single or alternate day dosing came? Here is the importance of understanding about hepcidin. So hepcidin is one protein which is produced in the liver, which actually helps with iron absorption. So what happens is there is one iron transporter protein, is ferroportin, which is there in our body. Through the regulation of that, this hepcidin actually is very important for iron metabolism. So moment you are taking acid, remember in the diagnosis part I told in iron deficiency, it will be very less, hepcidin will be very less. But the moment you are giving a high dose and maybe more than 60 mg in a day, sudden rise of hepcidin happens in our body, which will affect the absorption of the iron. Okay, this hepcidin will inhibit that ferroportin thing, which is the only iron transporter in our body. So, indirectly, what happens when there is an induction of hepcidin, that will decrease the iron absorption from the subsequent dose given the next day. So, if you give a gap of around 1 to 2 days, the hepcidin level will automatically come down, which will facilitate the absorption of the iron which we are giving in the next day. So that is why nowadays it is preferable to give either as a single dose or even alternate dosing and also having beautiful effects. So many reference studies are there related to it. So why lower dose? Again, one thing is if you give higher dose, there is induction of hepcidin, which will decrease the absorption of iron, number one. Number two, there are lots of reduced unabsorbed iron is there in our body, means what happens? That will favor the growth of E. coli, and more iron is there, it will go and get deposited as hemosider, and so many problems are there. And it is found that they both are having comparable efficacy. Then why I take high dose? So this is about the main insight, and follow up CBC at around 4 weeks. Whenever you are starting a patient on iron therapy, also tell them it will take time, and once it is normalized, we have to give another 3 months for restoring the bone marrow stores. About the intravenous iron therapy, persistent anemia with oral iron intolerance, indication is one of the indications that, and even malabsorption, non-adherence to oral iron therapy, GI diseases, chronic condition like CKD on dialysis, etc. Formulations, iron dextran, iron sucrose, ferric gluconate, ferric carboxymaltate, maltose, etc. are available. So, newer therapies like transdermal iron pads are found not to have much role in children. So, summarizing, early recognition and comprehensive management is crucial. Single dose of lower dose iron around 2 to 3 mg per kg. 3 mg per kg is what anemia strategy recommends, is preferred for treatment. Tailored treatment plan and continuous monitoring is essential to prevent a recurrence. I hope the session is clear. If any doubts or clarification required, please put it in the comment box, and kindly share this video to all your colleagues and friends so that we all will fight together to prevent anemia and also treat the cases of anemia in the most optimum way. Thank you so much and have a blessed day.